Welcome to the Study Neuro lecture series. In this session, we'll cover the examination of cranial nerve 8, the vestibulocochlear nerve, focusing on hearing and balance. By the end of this video, you'll be able to understand the key functions of cranial nerve 8, perform a focused bedside auditory and vestibular exam, and recognize common signs of hearing loss and vestibular dysfunction. Cranial nerve 8 plays a vital role in maintaining hearing and equilibrium. Careful assessment helps identify vestibular disorders, inner ear pathology, and possible brainstem involvement. Let's begin with a step-by-step approach to examining hearing and balance at the bedside. When examining the vestibulocochlear nerve, the focus at the bedside is hearing. This assessment helps determine whether a patient has normal hearing and, if not, whether the deficit is conductive or sensorineural in origin. Begin with a simple screening test. Assess each ear separately by standing behind the patient and using a whispered voice or a finger rub near the ear. Ask the patient to repeat the words or numbers they hear. This quick step tells you whether hearing is grossly intact and whether further testing is needed. If a hearing deficit is detected, move on to tuning fork tests. Start with the Rinne test to compare air conduction and bone conduction. Place the vibrating tuning fork on the mastoid process and then position it just outside the external auditory canal, asking the patient which sound is louder or lasts longer. This comparison provides key information about how sound is being transmitted. Next, perform the Weber test by placing the tuning fork at the midline of the forehead or vertex. Ask the patient where they hear the sound best. This helps determine whether sound is being perceived symmetrically or is lateralized to one side. In a normal examination, whispered sounds are heard clearly in both ears. Air conduction is louder and longer than bone conduction on the Rinne test, and the Weber test does not lateralize to either ear. Clinically, it is important to remember that Weber and Rinne tests are only necessary if the initial hearing screen is abnormal. In conductive hearing loss, sound lateralizes to the affected ear on the Weber test, and bone conduction equals or exceeds air conduction on Rinne testing. In contrast, sensorineural hearing loss causes sound to lateralize to the unaffected ear, while air conduction remains better than bone conduction. Together, these findings help localize pathology to the external or middle ear versus the inner ear or vestibulocochlear nerve. When assessing vestibular function, you're essentially evaluating how well the inner ear and its central connections are maintaining balance and keeping the eyes stable during head movement. This is particularly important in patients presenting with dizziness, vertigo, or unsteadiness, where the key question is whether the problem is peripheral or central. Start by simply watching the patient. Even before you move their head, observe the eyes at rest. Spontaneous nystagmus can be an early clue to vestibular pathology. From there, ask the patient to follow your finger slowly. This allows you to assess gaze stability and detect gaze-evoked nystagmus, which often points towards central involvement. One of the most informative bedside tests is the head impulse test. Ask the patient to keep their eyes fixed on your nose, then make quick, small head movements to either side. In a normal response, the eyes stay locked on the target. If you see a corrective saccade, this suggests impaired vestibulo-ocular reflex function on that side. Next, assess balance more globally. With the Romberg test, you're looking to see whether the patient can maintain posture when visual input is removed. Increased instability once the eyes are closed suggests a vestibular or proprioceptive contribution. Watching the patient walk adds further information. Veering or imbalance can reinforce vestibular dysfunction. In a normal examination, eye movements are steady, gaze remains stable during head impulses, posture is maintained with eyes open and closed, and gait is coordinated. Interpreting these findings together is what matters most. An abnormal head impulse test combined with nystagmus usually indicates a peripheral vestibular lesion, whereas a normal head impulse test in the presence of other neurological signs should raise concern for a central cause. The key takeaway is to rely on observation and pattern recognition. Vestibular testing is less about isolated maneuvers and more about integrating eye movements, balance, and gait to localize pathology accurately at the bedside. Before we wrap up, remember that the vestibulocochlear nerve plays a key role in both hearing and balance. A simple bedside exam can tell you a lot, from detecting hearing loss to picking up signs of vestibular or brainstem dysfunction. These findings are especially important for accurate neurological localization and early diagnosis. Thanks for watching. If this helped, drop your key takeaway in the comments. And don't forget to like, subscribe, and follow Study Neuro for more clear, clinically focused neuroscience content. More coming soon. Stay tuned.